Chapter 3 in the text talks about, we'll discuss the basic neurologic disorders and the neurologic examination. So really what I want you to get from this, it talks about some very specific tests for neurologic examination, and I don't necessarily, of course, as PTAs, we do not do neurologic examination except at retesting a certain thing. It's interesting to see what tests are used, but what I want you to get out of this chapter is I want you to get, number one, just the definitions of all the neurologic disorders, and get an overview of what is tested in a neurologic examination. I also want you to appreciate the difference between an orthopedic examination and a neurologic examination. And one of our discussion board this week is really I really want to hear your ideas of how you think treating an orthopedic patient is going to differ from treating a neurological patient, and get some ideas around that. So chapter 3, that's what I want you to get out of it. Chapter 4 is the one on neuroimaging, which is very interesting. We're not going to talk about it at all this quarter, but it's there if you want to look at it. You're not going to be required to know anything from that chapter. And it does have a nice neuroanatomy atlas in chapter 4. So on to chapter 3. The clinical application of learning neuroscience. So really that's what we're all about, right? The clinical application. So just in the way of defining things, we define a neurological lesion as an area of damage or dysfunction. So the signs and symptoms following a lesion of the nervous system depend on the location of the lesion. That totally makes sense, right? So if you have someone that has a stroke that affects one area of the brain, their signs and symptoms are going to be different from someone who had a stroke that affects another area of the brain. So the location of the lesion is really going to influence what signs and symptoms are displayed. So depending on their distribution in the nervous system, lesions can be categorized as focal, which means they're limited to a single location, multifocal, limited to several non-symmetric locations, non-symmetric lesions, or diffuse, affecting bilaterally symmetric structures but not crossing the midline as a single lesion. So focal, multifocal, and diffuse, basically. So events that can affect the nervous system, there are lots of them. So trauma can be a big one. Traumatic brain injuries and any kind of... I've been working with someone recently who started out with a fall with a brain injury, and it ultimately resulted in a hemorrhagic stroke. And so that whole trauma event cascaded the whole nervous system neurologic disorder. Vascular disorders, so anything that's interrupting the blood supply to the brain or the central nervous system can cause neurologic problems. Inflammation. So there are some chronic inflammatory or acute inflammatory neurologic disorders such as Guillain-Barré syndrome, which we'll talk about a little bit more in one of the later chapters. But inflammatory conditions can definitely affect the nervous system. Degenerative disorders such as multiple sclerosis, Parkinson's, Alzheimer's, those are all neurodegenerative diseases. Developmental disorders, that is something that happens either at or near birth, affecting the development of the nervous system, or it could be a pre-birth thing. Tumors, of course, tumors can block off blood supply. They can change the hormones that are being sent out. Tumors can do a lot of bad things, and they can cause neurologic disorders. Immunologic disorders, so things affecting your immune system can certainly affect neurologic nervous system disorders. Toxic or metabolic disorders. So we talked about in pathology encephalopathies that result from toxic or metabolic disorders, and that is certainly a major effect, a major cause of nervous system problems. So we did talk in pathology class about the incidence and prevalence of all disorders, not just neurological disorders, but I just want you to review the definition of these two. So the incidence of any disorder, neurologic or otherwise, is the proportion of a population that develops a new case of the disorder within a defined time period. So a non-neurologic example of that would be, I polled 100 adults between the ages of 20 and 40 and asked them if they got a new dental cavity within the last year. So a new case that developed within a defined time period. And so if, say, 10 of those 100 that I polled, usually it's extrapolated out to the number in 100,000. And so we'd say 10,000, the incidence is 10,000 within the last year, extrapolated from our sample size of 100. Prevalence is the current proportion of the population with the condition, including both old and new cases. So when you read the current literature on Parkinson's, they say about 1 million people in the United States have Parkinson's, and that is old cases and new cases. That's the prevalence of Parkinson's in the current population. So the neurologic examination has two parts, just like most physical therapy examinations. Taking the patient history and then tests and measures to evaluate the condition of the patient. So the history is a structured interview. We are going to classify the speed of onset as acute, subacute, or chronic. So you can almost think of it in terms of time. Acute is something that's happened in the last week. Subacute is something that's happened in the last month. And chronic is something that's been going on for months or years, if you sort of want to think of it that way. There are certain neurological conditions that have acute, subacute, and chronic stages. For example, say that I have someone who had a CVA. They had the CVA 2 days ago. They are in the acute stage, obviously. Once they have they've recovered a little bit, they're now undergoing therapy. Maybe a month later, they're in the subacute stage. The symptoms from a CVA do not go away quickly, so years from now they will probably be in the chronic stage because they will still be working on issues that resulted from their stroke. MS is another neurological disorder that tends to have acute, subacute, and chronic stages. There are, of course, different types of MS, and we will talk about this a little bit later. In the most common kind of MS, which is relapsing remitting, there are acute exacerbations where it gets worse, and then as you're recovering from that, you're in the acute stage, and then you have times when it remits, and you don't have as many symptoms, and that is in the chronic stage. So I would like you to be able to classify, given a short case study, I would like you to be able to classify whether the onset was acute, subacute, or chronic for an individual case study. So the purpose of the tests and measures in a neurological examination is to determine the probable cause of neurologic problems so that appropriate care can be provided. So in a physical therapy setting, we're trying to, we probably already have an evaluation from the primary physician or neurologist that has determined the probable cause, but the PT is trying to test to come up with the appropriate plan of care so we can really get that person to be as functional as they can possibly be. So in the book, for each test or assessment, they describe the technique and they describe the normal response and what structures are intact. And that goes for orthopedic tests as well. there's a technique, and we know what the normal response is, and we know what structures are involved if you get a normal response. So in the diagnosis, they are trying to determine several things. One of them is the lesion in the peripheral or central nervous system. Of course, that's going to affect the plan of care. Are the signs symmetric on the right and left sides of the body? That's certainly going to play into the diagnosis. Is the lesion focal, multifocal, or diffuse? Does the pattern of signs and symptoms indicate a syndrome? So we will talk in the spinal chapter about several different syndromes that have particular signs and groups of signs and symptoms, and in some of the other chapters as well. So sometimes it's a pattern recognition thing. Does this group of signs and symptoms indicate a syndrome going on? What region or regions of the nervous system are involved? Is it the peripheral nervous system? Is it the central? Is it the brain? Is it the spinal cord? Is it the basal ganglia? What regions are involved? And what is the probable cause? A lot of the chronic neurodegenerative disorders, they're idiopathic, meaning we don't know what causes them. But sometimes there is a specific cause. So usually with a CVA, they will say whether it was hemorrhagic, meaning there was excess bleeding, or something that's caused by a clot, which is more common for brains. So what's the probable cause of this diagnosis? And then what is the diagnosis basically? So in the screening exam, they're trying to determine whether there's a neurologic disorder, whether the signs and symptoms are consistent with a given diagnosis, whether the patient requires referral to another provider, like a referral to PT if this is a neurologist doing the exam or a primary care physician, and determining what neural systems require more investigation. So there might be more testing that needs to go on. I'm working with a patient right now who the preliminary diagnosis was Parkinson's, but he's having some different reactions to the medications. He's not getting the same reaction that you would expect someone with typical idiopathic Parkinson's to have. So he's actually, besides coming to PT to work on function, he has been referred to a movement specialist in order to investigate further and see if there's something else going on besides Parkinson's. There are a lot of other movement disorders that mimic Parkinson's, and part of how they determine whether it's actual Parkinson's or not is how they respond to the medication. So it's kind of interesting and a little bit scary, because some of those ones that mimic Parkinson's are way worse than Parkinson's. And so being referred to an additional specialist or provider might be a really important part of that exam. So in a comprehensive neurological examination, they examine a whole list of things: mental status, cranial nerves, autonomic function, motor and somatosensory systems, coordination, spinal reflexes, postural control, and gait. The comprehensive exam will give meaningful information for planning appropriate interventions. So there are special tests that are performed only when specific signs and symptoms are present. And the book lists a whole lot of them, which is, it's very interesting to read. You definitely won't be responsible for that information, so you might want to put aside of like, hey, I'll read this later when I have more time. Or if you have to look up a specific special test. So the categories of the neurological function are mental status, cranial nerves, autonomic function, motor function, somatosensory function, coordination, spinal reflexes, and gait. So all of those things are going to be tested in some way. And then special tests will be performed if a specific deficiency is detected. So one of the things that is different between an orthopedic patient in physical therapy and a neurological patient. In an orthopedic patient, they're generally going to have a typical path of recovery and return to function. Not to say that we're going to do a cookie cutter treatment for anybody. We're treating each person as an individual, but we have a predictable path that they're going to follow, and you can pretty well predict when a person with an orthopedic injury is going to recover, and you can give them a pretty good idea of how things are going to go. With a neurological patient, it is going to be much more of a gray area. Everybody reacts a little differently. There are days, I'm telling you, when I have several different stroke patients or several different Parkinson's patients, and each patient is so different. You can have someone with the exact same diagnosis, the same type of stroke, and yet their recovery is going completely different from another person with that same diagnosis, that same type of stroke. So it's really interesting. That's one of the things I really love about during doing neurological rehab is it is interesting. It is problem solving. Every day when you work with that patient, you are trying to figure out how things are working today, what you can do to work with them, make them work better. How can that individual person improve their function? So it's not cookie cutter at all. It's very problem solving oriented, and very interesting and stimulating area of therapy to work in. So that having been said, a lot of the interventions we do can be very simple. Very simple exercise, but the idea is that we're trying to improve the function in a particular neurological area by doing that simple exercise. A lot of times we have to break things down into smaller parts than we would for someone. Say we had someone who had a total hip replacement, and we're in the hospital with them the day after their surgery, and we're teaching them to do a safe transfer while not breaking their hip precautions. That is one level of teaching a transfer. And now say we have another person who it's their second day after a stroke, and we're trying to teach them to do a safe transfer. We have to deal with motor planning issues, with movement issues, with sensory issues, sometimes with communication issues. Lots of different things going on with the neurological patient, even though we're doing the same intervention. In other words, teaching them to do a safe transfer. It's much more complicated, and sometimes we have to break it up into smaller steps because of the neurological dysfunction. So very interesting area, lots of problem solving going on.